Well, this is a big problem. The best drug in the world is not going to work, obviously, if somebody doesn't take it. Interestingly, in psychiatry, they've been shopping around for a term to describe this, and no kidding, I'm not making this up. In the 1940s and 50s, they called it faithlessness. The patient had no faith, in the drug or in the doctor, so that kind of fell by the wayside. Non-adherence is probably the one that's used the most currently. Non-compliance, the word compliance sort of suggests passive submission to somebody, so many psychiatric disorders are really characterized by profound sense of powerlessness. So I think that people certainly want to try to get away from that. Okay, well, this is a teaching hospital. Okay, here I want to talk for just a moment about non-compliance in general medical patients, and you can see in this slide, and there are really lots of studies with different kinds of illnesses, hypertension and diabetes and you name it. Across the board, 50 to 60% of people treated for these chronic medical illnesses either discontinue medications or do not take them as prescribed, and this is a very big deal. This is just for you to look at in your leisure, but here are a list of very common chronic medical illnesses where non-compliance can be enormously problematic and also can lead to people dying. In general medicine and in treating severe psychiatric disorders, the number one cause of treatment failure is not taking medications as prescribed. It's not wrong diagnosis, it's not the wrong treatment that's provided, but it's simply that the patients are not taking the medication. And this is a big issue in psychiatric disorders, and I think we talked about this before in the section on depression, but if you look, 30% of people with major depression who are given a prescription in primary care setting by their doctor never even take it to the pharmacy. And what that is about, it's about pessimism and hopelessness. And we've got to know the nature of the disorder that we're dealing with, that high rates of noncompliance early in the game, either for those reasons or, as everybody knows, the antidepressant's taking several weeks to start working, and that's real hard for people to continue to take that without feeling anything better. You can see more data up here about problems in primary care. There's been attempts to address the problem. The one that's been used the most is to provide additional educational information about the medication. And this could be watching a video, could be information sheet that's given to the patient. Certainly, the physicians and other prescribers have a little bit of time to talk about some side effects and say, please call me if you have a problem. But across the board, in this particular reference here, they did sort of meta-analysis, 26 studies. They found that educational programs have face validity, but they don't work. They don't work for a lot of problems that we're going to talk about right now. Now, the STAR-D program that we looked at earlier, this is the largest study of treatment of major depression with medication sponsored by the NIMH. And after a number of different trials on medications, eventually they get up to 67% remission, which is pretty good given the fact that they were treating people who had very severe depression. Okay. However, this is really interesting, and that is half of these patients were getting treatment in primary care, believe it or not, and they were doing just as well as the psychiatrists. How come they did so well there when we all know you can't successfully treat depression in primary care usually, and it's aggressive treatment. They follow the protocol, and they have specific times, dates, that if you didn't respond within 28 days, then you increase the dose by so much. So it wasn't sort of fly by the seat of your pants. It was a specific program, a protocol. Also, keys to success, and this is not used, it's used hardly ever in primary care. People were seen weekly. If for any reason they can't come in, they had a telephone conversation, follow up. Okay, they really stayed on top of not only rating improvement, they had a side effects rating scale, and the use of rating scales, according to the authors of the study, was a significant factor in staying on top of what's going on, and the patients liked it, and it really contributed to success. However, there are 4 different stages. Step 1, as you remember, was treating everyone with Celexa. Those people that did not meet remission then went to stage 2 or phase 2, and they either got a different medicine or they had an augmenting agent. And eventually, most of the people got better, and 67% of people actually reached full remission. But here's the big but, all right? Every time they went to a new phase, they lost between 10 and 15% of the patients, even though they were not recovered. And this is not going to surprise any clinician to hear this. I'm going to be talking about some very useful information drawn largely from this book by Dr. Sean Shea. I highly recommend this book. It's very user-friendly, and it's got tons of good ideas. I'm going to be sharing with you just some of those here today. And so this is the name of the book and the author, and you'll have that in your handouts. Let me just read this to you, okay? My goal, this is Dr. Shea, is to always give you good advice so that together we can find a medicine that you will genuinely be interested in taking. Please always let me know what you think about the medications you're trying, and I'm counting on your input. And at the heart of a lot of what he says is a collaborative kind of model, and really making a big deal about keeping the doors of communication wide open.